Hi and welcome to this planetary health themed session for SSRP Week on joint action on sustainable development goals for public health and conservation. My name is Gladys Kelema-Zikusoka. I'm a fellow at the Sussex Sustainability Research Programme, and today we've got two speakers here to present to you today. We've got Jo Middleton, who's here in person, and also Gladys Kelema-Zikusoka, who will be joining us virtually. So before I give more of an introduction on our speakers and what they're going to be talking about, I'm going to introduce Jo Alcamo, who's Director of the Sussex Sustainability Research Programme and Professor of Environmental Systems Science, who's going to be explaining what the Sussex Sustainability Research Programme is and what this week of events is all about. So,
right. Very good. So Jo suggested I speak from here, so I'm on camera, which means that I'll be a bit peculiar for you folks, but hopefully you don't have any neck problems, at least not any neck problems as a result of it. So anyway, the SSRP is a research program that cuts across several schools and IDS on campus, and we are concerned about science for the SDGs. And one of our flagship projects is, you'll hear about it from the first speaker today. But what I want to say is that if you're familiar with the SDGs, then you're probably also aware that we're lagging behind almost all of the SDGs at this point, which is a bit depressing amongst all the other problems you have to worry about. But so now we're looking around for new ideas, some exciting ideas, and how we can make progress with the Sustainable Development Goals. And one idea that's emerged from the SSRP is this idea of synergy drivers, projects or initiatives that can accomplish more than one SDG at the same time. And we derived this idea partly from the project you'll hear about in just a few moments, the idea of combining public health and conservation and forest resources in the same project in some creative way. And as part of our phase 2, which we're kicking off this week with a whole week of activities, we plan to give special emphasis to some of our projects over the past 5 years. And this in particular is one of them, that we're hoping to scale up the big idea of achieving SDG 3 and 15 at the same time through this exciting idea of combined public health and conservation in the same projects. So I'm very happy to welcome you all here. Also want to welcome you to join in SSRP activities. If you're not familiar with us, via our mailing list, look for us on, look at our webpage, look at us for us in social media, however you get in contact, or walk up to me and ask me questions after this, the old-fashioned way. So thank you very much for the opportunity to say a few words about SSRP, and back over to the chair, Jackie.
Thank you, Jo. So I'm going to give a
Jessica, excuse me.
That's okay. I'm going to give you a bit of an intro on both our speakers. So we've got Jo Middleton here, who is a research fellow working at the Brighton Sussex Medical School in both the Department of Primary Care and Public Health and the NIHR Global Health Unit on Neglected Tropical Diseases. Jo is also convener of the planetary health theme at SSRP, and in his work as part of SSRP, he is co-founder of Surfaces PNG with Professor Alan Stewart, who's just back there. Thank you, Alan. Surfaces PNG is integrating conservation and health in the threatened rainforests of Papua New Guinea. Jo will be talking about on-the-ground work in Papua New Guinea, or PNG for short, integrating action for SDGs on health and conservation, global mapping of similar projects worldwide, and funding barriers to such synergistic work. We also have Dr. Gladys Kelema-Zikusoka, who is founder and chief executive officer of Conservation Through Public Health. Now, Conservation Through Public Health is a non-profit organization that promotes conservation by improving the quality of life of people and wildlife to enable them to coexist in and around protected areas in Africa. Gladys trained as a veterinarian at the University of London's Royal Veterinary College and went on to set up the first veterinary unit at the Uganda Wildlife Authority in 1996. Since then, she has been the subject of a BBC documentary, Gladys, the African Vet, and just yesterday it was announced that she is the winner of this year's Tallberg Global Leadership Prize, awarded annually to well-established individuals whose leadership is courageous, innovative, rooted in universal values, and global in application and inspiration. She's talking about the success of He will be talking about the success of conservation through public health and integrated action on SDGs for public health and conservation in Uganda. So we're going to have Joe first. So whenever you're ready, Joe.
Thank you. So I'll be talking, as Jessica said, about two aspects, both on the ground work in Papua New Guinea by Sustainability Research Programme and our collaborators, but also global mapping of similar projects worldwide. So there's quite a lot of names there on the first slide because I don't want to give the illusion it's just work by myself, especially when it comes to the global mapping work. I've had a large number of collaborators, about 48 institutions have submitted data for this global map. So, first of all, some background on Papua New Guinea. So Papua New Guinea is a hyper-diverse, in terms of biodiversity, country. It's the most floristically diverse island on Earth, yet its forests are threatened by logging, mostly driven by commercial demands from commodities worldwide. The population is increasing, it's got about 7 million people, but the main threat to forests is not in any way subsistence, it's commodity-driven commercial logging. So Papua New Guinea is also unusual in that it's extremely ethnically diverse. So a third of all the world's languages are found in New Guinea. And importantly, though the clans linked to those languages maintain land rights to where they live. This is incredibly unusual globally. So 97% of the land of Papua New Guinea is owned and claimed by clans. It's owned communally, not by individuals. So the key to conservation in New Guinea, which is the third largest rainforest on Earth, is going to be the ability to work with Indigenous communities to support them in their aspirations in a way that enables them to preserve the forest, while simultaneously getting access to the resources a sustainable development way it wants. Now, one real problem in Papua New Guinea is that the health system is relatively undeveloped. So it's got secondary hospitals in some of the core towns, very little primary care out in the community. So much of the country is very remote. So if you imagine you're in a remote forest area, well, if I'm going in as a kind of biodiversity scientist or as, as a medic, when I see this picture here, what am I seeing? I'm seeing kind of the intrusion into the forests of kind of logging. I'm thinking about habitat fragmentation. I'm thinking about the introduction of alien species, etc. That's very much an outsider perspective, the perspective from somebody going into the forest. If I was at the end of that logging road in a remote community with no access to existing medical care, and my child was ill or I was ill, then that road might be a lifeline to get out to hospital. So therefore, we've got a bit of a trade-off there. Communities lacking medical services sometimes are incentivized to allow logging so that they can get access to where the medical care is, and also some limited amount of cash to pay for medicines from pharmacies. So the project where we've been working, which is in Madang province, is very remote. So you would have to go 4 hours up logging roads like this, and then walk 2 hours through the forest, including kind of going up to your, above your waist in informal river crossings, and then a couple of hours more before you even got to the first least remote village in the collaboration. So I'm going to talk to you about what we've been doing on the ground to kind of avoid that trade-off and bring the synergy between health services and conservation. So in the first stage in 2018, funded by Sussex Sustainability Research Programme, a team of us from Sussex, along with colleagues in Papua New Guinea, went and did a combined clinical and rapid anthropological assessment of medical needs and perspectives. So this was part of co-planning with the community themselves, who've had a long-standing conservation agreement for some of that, said the next thing they needed in that collaboration was access to in-community health services of some kind. So with kind of ears open, we went and spoke to them about what their perspectives were, we did focus groups, we did interviews, and at the same time, we triangulated that kind of qualitative data with quantitative data from clinical examinations. So we had general practitioners, and I was examining most of the residents of the community to see what existing medical conditions they had. And obviously, given that this was the first time a medical doctor had ever been in this community, it would have been unethical for us just to collect data as kind of researchers without treating urgent cases. So we also treated urgent cases as we found them. In fact, the majority of people we assessed did have some immediate medical need. So we did that data collection out in these quite remote villages, and then we used that data to get some money from UK aid, from the Darwin Initiative, and that's funded a project to build a clinical aid post in the community, staff it with a trained nurse, provide medicines, etc., as well as other services. So in 2019, before that was in place, I went back, I've got an emergency care background from the ambulance service, etc. Went back and taught medical evacuation, how to do malaria diagnosis and treatment, because often people using very much the wrong medications to treat malaria, and just to empower the community with some basic skills while waiting for the next stage of our work. And then in 2020, we opened the Sussex and Middleton Research Centre jointly organised kind of nurse aid post there in 1A. First time we've had medical services were in that area, about 500 square kilometres. And simultaneously, we've been doing some mapping of similar projects worldwide, so we can learn lessons from other projects. So what are the kind of outcomes of this work? Well, we very much from the beginning, we're looking at doing synergistic work across sustainable development goals. And the topic today is around health and conservation, but given we've obviously got a COP going on around climate, I'm going to mention something briefly about the climate impacts of our work as well. So we have 15,000 hectares of conserved rainforests, about 150 kilometres square of forest conserved. This includes new conservation areas, a new no impact zone, and we've also got a regenerating buffer zone. So Simon Stewart's been involved in supporting community conservation in that area for 15 to nearly 20 years. And this community decided themselves to conserve their core forests, but all the communities around them had allowed logging. So 15 years later, there's a threat again coming of loggers coming in to log the regrowth of the secondary forest and also maybe go after the primary forests, both in the conservation area and forest fragments. So working with communities outside of the existing conservation collaboration, the project has expanded it by 50% to include areas both of primary forest, but also secondary recovering forest, which had been previously logged. So we've created a kind of protective arc around the main conservation area, both expanding it spatially, but also blocking loggers from coming into the area generally, both our area and actually a much larger area behind us. So that's been very successful, and we're seeing good natural succession. It has been measured in the buffer zone. 9 new villages who weren't originally involved in the conservation collaboration have been brought in, and we've seen improved attitudes to conservation. So in over half of the households, we saw significantly improved attitudes to conservation once the health post has been put in. So that's an attitudinal change directly as a result of medical provision. And importantly, we've also been building capacity in Papua New Guinea for conservation science. So this isn't something which is kind of parachute science where we're going in from Sussex. We've really been building institutions on the ground and training people. And in fact, the Middleton Research Centre, which has come out of these kind of projects that Sussex has been doing for 20 years, is now the largest non-medical biology research institute in Papua New Guinea. And you can see some of the staff at work in those buildings there. That's Middleton Research Centre. The building on the right is a kind of student teaching and accommodation space built by Sussex. So we've also been improving SDG health and health service indicators, and we've been quite tightly measuring our outcomes against SDG sub-targets. And if we're going to make arguments that this really is contributing to SDGs in anything other than a very vague way, we should be tying our interventions to specific sub-targets, not just the SDGs in total. So to give you an idea, so we've introduced primary care for 2,000 people without any access to community care, acute care, 500 square kilometres, and also doing mobile patrols. That fits with SDG 3, which is about health worker density. We've been doing vaccinations, especially to children in the area, so that's a specific SDG target. We've supported maternal childbirth in this remote area, including multiple incidents where I'm sure mothers would have died actually without the nursing setting, placental retainment, etc. And also neglected tropical diseases we've been targeting. So we've seen nearly 90% decrease in neglected tropical diseases since the intervention started, and we've got good baseline data to evaluate against our ongoing data collected to evaluate the project. So, as I say, it's been a 3-stage approach, starting with training and empowering the local community, then building primary care in the community, and now we're moving on. Once we've kind of built the primary care aspect, we're going after proactive disease targets, which were found through our kind of rapid anthropological assessments and clinical examinations. So we're specifically looking at yaws as one of those skin diseases, tinea imbricata. You can see it's the third one on the right. That's called puk in the local language, which means crocodile because it creates this huge level of kind of broken skin that looks like the skin surface of a crocodile all over the body and can last for up to a decade, and also scabies and tropical ulcers. So although the main focus is on health and conservation SDGs, so we are thinking about climate change, especially this week, so it's worth thinking about its effect on climate. And within the main conservation area, there's been some work done by Dr. Mika Peck here at Sussex. A team went out and they measured the amount of carbon that's being sequestered by the conservation area. You can see we've got a very large amount of both biomass and then carbon being stored by the forest. So obviously we need to think about reducing carbon emissions, keeping fossil fuels in the ground. But an important part of dealing with climate change, to the extent that we can now, is keeping the carbon in those forests and preserving those stocks of carbon. And our project has been taken up as a kind of national role model. So given that Papua New Guinea has the third largest rainforest on Earth after the Amazon and the Congo, hopefully the work we're doing in Wenang will follow on and much across influence the nation. So that's the kind of update on what we've been doing on the ground. And now to quickly go to thinking about this global mapping work, and I say this work I and Alan have been doing, but also Gladys will be speaking later, has been contributing to it. And we've had 48 institutions who've contributed data. We found 43 projects across 22 countries since 1980, which have integrated specifically the provision of medical services with conservation outcomes. So there's many other types of integrated health and conservation. Maybe you're kind of preserving upstream water supplies to stop downstream diarrheal diseases and underflies, for instance. Maybe you're in the UK, you're encouraging park recreation to both preserve biodiversity in national parks, but also improve fitness and reduce chronic diseases, lifestyle diseases. So there's many types, but we've really focused specifically when there's been explicit medical provision with outcomes for both biodiversity and health improvement. As you can see, the most common area was in the tropics. Sub-Saharan Africa was by far where most of the projects were, followed by Asia and Southeast Asia. The kind of interventions were tropical wet forests and tropical dry forests with a leading habitat, but also we saw other habitats involved, corals being very common. And in terms of interventions, the most common medical provision given was family planning. But even where that was being given as the primary focus of an intervention, in nearly all cases, other medical services were being provided. And the second most common medical intervention being provided was straightforward primary care, so usually clinic building, etc. On top of that direct medical provision, most of these projects were doing conceptual work where they're using education to link continued ecosystem health to local public health with the communities. Other work involved things like reduction of zoonotic disease spillover, which, given what we know about COVID now, is very relevant. So I'm going to give you two projects which encapsulate the differences in the kind of projects that we've brought up. And obviously, in a bit later, we'll be joined by Gladys, who'll be talking about her really inspirational project, which has provided a lot of the thinking and the kind of conceptual basis of the work we've been doing in Papua New Guinea. So one really well-known project is ASRI, Health in Harmony. That's in Indonesia, but it also spread elsewhere. So they've been working in a national park with a large number of impoverished people living outside of the national park borders. This is also a major site for orangutans, and there was a problem that people on the outside of the national park were going in, logging informally to pay for medical services, in effect. So this is quite different than the situation in Wenang. In Wenang, the community lives in the conservation area, they maintain land rights to it. Here, we've got a situation where there's effectively a national park and the community are on the outskirts of its borders. It's a bit more fortress conservation. So this, to kind of work with the community and see what they needed, some radical listening was done by Health in Harmony. And what the community said is, well, they're going to have to carry on doing illegal logging if that's the only way they can get some income to pay for medical services. So what they've been doing is they've put in healthcare, so mobile patrols, a permanent clinic, in fact, a small district hospital, and at the same time link that to reforestation and forest conservation. They've been very successful, both in terms of decreasing the illegal logging within the protected area, but also in terms of improving health and bringing all the community involved. So it's an initiative by them, not an initiative done to them. You know, there's obviously always an issue with colonial conservation sometimes, and I'm glad to say that they've very much embraced community-led approaches. So this was a project which has been going on for about 10 years now. It's been evaluated and published in Proceeding International Academy of Science is really good evidence that these kind of synergistic work does work. But it was very much started with that kind of principle. So it was starting about health and conservation at the beginning. Many of the projects which we found in mapping didn't start like that. And the good example is going to be this one run by the Royal Society of Protection of Birds in the Angola Red project in Sierra Leone. Now, the Royal Society of Protection of Birds, for those who don't know, is a kind of UK-based but internationally operating bird conservation organisation, which really started back in the 19th century by women trying to stop the fashion for tropical bird feathers in hats. So that's where its origin is. It's very far away from Sierra Leone, very far away from thinking about medicine. So they had a very large amount of money come in from climate funds to support a community to preserve 70,000 hectares of forest. And when the idea was that this money would be transferred to the community, managed in part by RSPB, but under the control of the community, for whatever the community felt was necessary. And the idea that the RSPB came in was, oh, we're going to support livelihoods, we're going to support, things like honey production and other ways to get basic income. So they spoke to the community and they were surprised that all their nice ideas, which they concocted, in their projects, actually were not primarily what the community wanted. What they wanted was healthcare. So as a result, RSPB ended up building an entire district hospital, which is now run within the government system. And this there's kind of interesting things about this. First of all, we know that Ebola, for instance, is caused in part in terms of its spillover by habitat fragmentation from logging. So preserving this forest is going to reduce spillover events somewhat. But also, the one big Ebola outbreak that happened about 6 years ago, this was the first hospital that dealt with people fleeing from that area and really had a big impact on outbreak control. So this is a very different situation really than Health in Harmony, who went in from the beginning with a synergistic approach, and this represents more common situation that conservation organisations are working with communities, and as a result of community demand, providing medical services as kind of bolt-on to their existing programmes. And as you can see, in terms of SDG 13 with climate, this has preserved large amounts of CO2 in the area as well. So overall, we found integrating medical provision and conservation is much more widespread than you'd expect looking at the academic literature. So of 43 projects that we've included in our mapping, less than half were actually ever published in the academic literature. Most of them are from direct data submission from the non-governmental organisations involved. And we've reached out through things like the International Union for Conservation of Nature, World Health Organization, Planetary Health Alliance, to kind of get that data submitted. Also, we found that there's some really good quality evaluations, which are showing that this approach is successful in some places. However, some projects did lack reliable evaluation processes. So if you can see on this chart, you've got health outcomes in one direction, conservation outcomes in the other. These are the outcomes which were listed in the theories of change from these organisations. So we collected not only where they were, what these projects did, who funded them, we also collected what their kind of theory was, what their outcomes were. And we found that very many of the projects couldn't directly prove that one outcome led to another. And there was a number of reasons for this. Often this was a response to say by local NGOs that didn't have academic partners, etc. But one key thing actually was to do with the funding mechanisms for these kind of projects. So we found funding is usually provided on a siloed basis for either health or conservation. That was a strong message coming from many of the projects. And this is a major barrier to evaluation. So if you get funding for health coming 1 year and funding for conservation coming another year, your kind of metrics are going to be mismatched. It's going to be very difficult to evaluate connections between these things. So one story that we had is, for instance, a really good conservation project in Brazil, expected to get funding from a funder who'd supported in the past, but because it had a health aspect, they said, oh, you should be going to a health funder, even though the evidence this would have substantial impact on conservation. So there's a real issue here with kind of siloed funding. And so what we're going to do in the next step of our work is look towards building an international roundtable of funders and practitioners doing this kind of work to think about creating evaluation rules to be embedded in funding rules so that these synergistic interventions can be supported by kind of global health funding and conservation funding rather than somewhat barrier. So we'll soon publish our full results and intend to repeat this kind of mapping every 2 to 3 years, and we'll be carrying on with the project on the ground in Papua New Guinea hopefully expanding to elsewhere in Melanesia as well. So this is some of the institutions involved worldwide in our mapping project, but our on-the-ground work, of course, would not be possible in any way without the input of those on the ground from Binnetown Research Centre, and most importantly, the Indigenous community, which has very much led the whole process. So that's me done for today, and I'll hand back to the chair.
Thank you. Thank you, Joe. So now we've got Gladys, and Carlos is, can you hear us, Gladys?
Yes, I can.
Brilliant. So
I can.
whenever you're ready.
But thank you so much for inviting me today to speak. And Joe's presentation has been fantastic, introducing all the different projects around the world that are integrating health and conservation. We founded Conservation Through Public Health almost 20 years ago in 2003, based on experiences I had while setting up the veterinary unit of Uganda, which I'll briefly talk about, and very encouraging because I became an for mothers' ones programs to create common resources for people and animals, social entrepreneurs. They supported me because they saw it as a new idea, which can have global implications. I'm really glad that almost 20 years later, One Health is now something that everybody's talking about. It's taken a long time, you know, for people to understand why you should integrate health and conservation together. And I got the Edinburgh Medal this year for our work in planetary health. And I was happy to join the WHO Special Advisory Group for the Origin of Novel Pathogens, because while we're still trying to determine where COVID came from, other previous coronaviruses and other previous pandemics or disease outbreaks that had occurred at a smaller level. And I was very excited yesterday to win the Global Leadership Prize, and that they're recognizing that merging human and wildlife health is something that has global significance. I was really excited in 2021 to win the UNEP Champions of the Earth Award in Science and Innovation, together with another One Health advocate, Dr. Fabian, that One Health is a way to achieve conservation and sustainable development, and very important to empower the local champions where the wildlife is found in order to make this happen on a sustainable level. I've been working with mountain gorillas for over 25 years, and the main ones we're working with are here in Bwindi. This population was discovered in the late 80s. This first one was discovered much earlier on in the 70s, and that's where Professor George Chala and late Dr. Dan Fossey worked. Then the Bwindi population was discovered a few years later. And altogether now the number of mountain gorillas has grown, which we're excited about. But they're still separated by, these islands will never meet, these populations will never meet because of building up in the area. So we're still dealing with one of the most endangered species and least numbers in species, but bringing a lot of tourism and reducing poverty for the people in these two areas, which is encouraging. So some of the threats to gorillas, habitat loss, as I mentioned, is a very big threat. Almost all around Bwindi and even Virunga, you find a very hard edge between the community and the park, and which meant that when it became a national park, people couldn't go in to cut trees. But once the wildlife was habituated, especially the gorillas, they started to come out and they like to eat people's banana plants. So very often you get human-wildlife conflict. Unfortunately, it happens quite frequently. And this resulted in this baby gorilla getting scabies because his group went out to the park to eat people's banana plants, and people put dirty clothing on scarecrow to chase away gorillas, baboons, and other wildlife. And gorillas, being curious, touch the clothing, and the mite spread through the group. And because they're living in surroundings where they're not getting treatment, there was a lot of reinfection, and this baby gorilla died, but the rest luckily were able to save their lives with ivermectin treatment. But this is the time when I started to think of the importance of improving community health in order to protect the gorillas. And this was in '96 when I was working as a first veterinarian for the Wildlife Authority. A few years later, more gorillas got scabies in another part of Bwindi, which had even poorer communities because there's no tourism yet. And this made us really think that we need to start improving community health where wildlife is ranging. We also had other cases such as this one of this gorilla which had a rectal prolapse, but we're not sure whether it came from picking up a parasite from humans or whether it was some other parasite. But this particular gorilla wouldn't have recovered without surgical treatment. She recovered and went on to produce other babies. And it became more and more apparent that we needed to improve community health in order to make sure that the wildlife is healthy and their habitats are secure. So we founded Conservation Through Public Health in 2003. And together with my husband, who's a telecom expert and a vet technician called Stephen Rubanga, who had worked for many years in the Ministry of Agriculture. And this is what you get when you get to Bwindi. This forest is not only important habitat for gorillas, but here we have elephants, we have chimpanzees, we have over 300 species of birds, 200 species of butterflies, and 4 other species of monkeys, and we also have baboons. And it's a very important water catchment area. And as long as you're protecting a charismatic species like the mountain gorilla, there's less deforestation and you're enabling climate modulation with this. So it's very important to do that. And this is the view from our office, if you happen to get there one day. We have 3 integrated programs, wildlife conservation, community health, and alternative livelihoods. And within these programs, we started off mainly with the wildlife conservation and community health, but we found that many people are unhealthy because they're poor, and we added alternative livelihoods. We enable people to coexist with wildlife by improving the health of the animals, the people, and the livelihoods of the local communities. And our vision is for people, wildlife, and livestock to live in balance, health, and harmony with local communities acting as stewards of their environment. In the wildlife conservation program, there's a big focus on wildlife health and habitat conservation because the species live within a habitat which needs to be protected. And with the community health program, we focus on strengthening community-based healthcare. So we work with community health workers and teach them to do conservation work. And we also work with community animal health workers and teach them to do conservation work. And then with alternative livelihoods, we started a social enterprise called Gorilla Conservation Coffee, when we found that farmers living around the park were not getting a good market or steady price, and they were still entering the park to poach and collect firewood, which wasn't helping. And we also found that giving group livestock projects to the local communities helped them, especially our volunteer groups, to keep going. This happens very much. Gorillas going to eat people's banana plants. And so we do a lot of comparative disease investigations, both of gorillas inside and outside the park, working with gorilla guardians who had them back and the park rangers, where we regularly collect fecal samples and compare with what we're finding in the livestock and people at our Gorilla Health and Community Conservation Center here at Bwindi. These are students from University of London and Dublin, that students studying parasites and stress hormones with Stephen. I developed this brochure in my last year at the Wildlife Authority because everybody was concerned that gorillas were getting sick, and me being the only vet in the organization had to come up with a public health program. And this was a turning point in my life when this happened. And we developed these brochures, both in English and the local language, and went to 1,000, we visited 1,000 people in 8 villages, especially the ones where gorillas were frequently coming out. And most of them were very willing to listen to what we had to say because gorilla tourism has transformed their lives. It's really lifting people out of poverty. Those who were not so willing to listen were the ones who had not yet benefited from tourism and wanted to benefit soon because they had seen that their neighbors were benefiting. And we do a lot of behavior change communication. This lady is giving a presentation to her community, talking to them about why we should be healthy and hygienic. And when you have the number of children you can manage, you're more likely to take care of them and less likely to have to enter the park to poach and collect firewood, and you're more likely to provide for them help. And what we're excited about is half our volunteers are men and half are women. It wasn't something that we had thought about, but it was an unintended outcome, which we're very excited about, because the women were planning and the men in conservation and natural resource management. And now with this gender disparity being reduced, where half are men and half are women doing couple peer education, men are getting more involved in healthcare and women in conservation and natural resource management. And so she's changing people in her communities, where we have the family that's doing things well and the family that isn't doing things well with different outcomes. And then we partnered with Family Health International when they were trying to see whether lay community health workers are able to safely give injections for family planning, Depo-Provera, without injection reactions. Because what they'll find is people go to the local health center and they find an overworked nurse and midwife who are attending to sick children, and they don't have enough time to give them injections. And then they go home and conceive, and they have, we're having people with 10 children per woman, not even per family. And they had a very large unmet need for family planning. So the most popular contraceptive was Depo, where someone comes to somebody's home, gets an injection, and then is able to go home and not have to conceive. And so this is something that we did together with Family Health International. We're one of their pilot sites in Uganda. There are 5 pilot sites, and it became a national policy, and they took it to Kenya and other countries. So excited to be part of that research to policy engagement. And this has all resulted in very good outcomes for the gorillas. Hygiene, we focus on hygiene and sanitation. This is a typical home. The kids are almost all the same age, but through our program, women are not having babies every year, and this is drastically reducing. So there's good hygiene and sanitation. People are taught how to prevent scabies, HIV, TB, and other respiratory diseases and diarrhea diseases. And more over the past 2 years, there's a focus on COVID-19. We're promoting voluntary family planning, the benefits and the methods. They talk about nutrition and sustainable agriculture, and they report homes visited by gorillas. Then the gorilla guardians come in and have them back. They talk about zoonotic disease awareness, which has really gone up now since the pandemic. The awareness on this, and currently, unfortunately, we now have Ebola in Uganda. So that's the next focus. And it's likely it's not near where the gorillas are, but it's in other parts of Uganda. We've had about 50 people dying of Ebola, sadly, and 6 health workers. But they also talk about the importance of the gorillas and protecting the forest and not poaching, and how they can benefit from ecotourism. Out of the 270 volunteers, they're able to actually reach over 6,000 households and 30,000 people in these households, which is great. And then we sustain them with group livestock projects, group cattle or group goats, which they've reinvested into village saving and loan associations, which was something we're excited about. When CARE was promoting them, our volunteers also developed their VSLA, which was another unintended outcome. And we haven't had volunteer dropouts over the past 15 years when we started this particular program. We're pleased that in the past 25 years, the mountain gorilla populations are going up. I participated in the very first gorilla census at Bwindi in 1997. And we're pleased that they're showing a positive growth trend. And as a result, mountain gorillas are no longer endangered and critically endangered. They're now being downgraded to endangered. The other gorilla subspecies, even if they're more in number, like the Western lowland gorillas, which is close to gorillas, almost 10, the numbers are going down drastically. There isn't any community interventions, there isn't any community health, no tourism in most places, and this is not helping. So we believe that bringing such benefits to such populations can really help to reverse this trend. And some of the impact we've seen is that gorillas are better protected in community land because people know these gorillas are helping to lift us out of poverty, and they're developing a greater understanding of how to reduce human-gorilla conflict. We've had a 3 to 7-fold increase in homes with hand-washing facilities. We started down
Gladys, I think we've lost you.
Gladys, we can't hear you at the moment.
Can you hear me now?
Yes.
Yes.
Okay. Had a bit of a problem with my phone. And then had reduced Jadia in the gorillas, which has been good because as community health improves and there's no open defecation in people's homes, the Jadia in the gorillas has gone down. I've had Jadia myself, so it's a problem in that area, but it's going down in the gorillas. And as community health is improving, it's also reducing in the communities. There's been a huge increase in women in family planning. We started off at less than the national average, but now we're above the national average, 22% to 67%, a threefold increase. And also the number of children per home has gone down to 4.1. It used to be over 10 in the Bwindi area, and 4.1 is less than the national average in Uganda, which is around 5. And we've had reduced gender disparities, which we're very excited about. We have been advocating for population health and environment, and we hope to start up the Uganda Population Health and Environment Working Group, which is a group of health and conservation NGOs who get together and talk about the various ways that we can integrate health and conservation to have more holistic outcomes. And this was supported by Population Reference Bureau. And some of the things we've done is we've continued to, I should make it full screen actually. We've continued to advocate for One Health. And over here, we brought partners from DRC and from Mount Elgon, Kenya side, to talk about a One Health approach to conservation, scaling up the village health and conservation team approach. And we wrote a policy brief together under the Uganda Poverty and Conservation Learning Group, of which CTPH is a part, and where we convinced them that healthcare is another very important dimension of poverty and can be addressed through a group like the Uganda Poverty and Conservation Learning Group. And through this, the study was done by Oxford University to see how the health investments that conservation through public health has made, if they're benefiting conservation and sustainable development. And one of the things we really advocated for is for all village health teams around the country to become village health and conservation teams. It's a very ambitious, ask, but we believe that if it happens, it's going to be much better for sustainable development. In DRC, we are working also with communities who are much poorer than Uganda. Most people just have temporary homes, and this is actually a kitchen. But people in DRC are very willing to adopt family planning because they're tired. They don't want to have so many kids, even if it's largely Catholic, where people are not encouraged to go on to take contraceptives because they want to reduce poverty in their home. So we're glad that our program is working well there. But during the pandemic, we had another new threat, which everyone had in the world, but it was even worse down there where people are getting close to great apes in the gorilla and chimpanzee protected areas. So we hope to upgrade the gorilla viewing guidelines in Uganda, where now everybody has to wear a mask when they visit the gorillas and the chimpanzees. And this is something that is continuing even after the pandemic is coming to an end. We also, one of the other things that we did was to improve on the community side, where this poster was made for communities, but now there was something about gorillas. If you see gorillas in your gardens, please call the right people to herd them back and put on a mask. And we also carried out some testing of people and gorillas for COVID-19, working closely with the Wildlife Authority and the Uganda Virus Research Institute. And in this way, we're able to mitigate the impact of COVID on the mountain gorillas. We also train the human gorilla conflict teams so that when they're herding gorillas back, they put on masks and they help to carry out the education and sensitization. And everybody now has to have their temperature taken before they visit. And the village health and conservation teams, we continued working with the same structures to reduce the impact of COVID and carry out a lot of, case detection, contact tracing, and they also help to coordinate the village COVID task force, which was set up when we had the Delta variant in Uganda. They asked us all to do it wherever we work. Our organization sits on the Ministry of Health Task Force for diseases, for COVID, Ebola, and other diseases, and they wanted CTPH to help in this area. So this was an area that the village health and conservation teams really worked on to prevent mild cases becoming severe cases that then require hospitalization, when there was no oxygen and no beds. And on these COVID task forces, we also had the park rangers and the porters who carry tourist luggage to the gorillas. And they were able to know homes that have COVID and stop such people taking tourists to the gorillas, even if they're feeling well. And we isolated sick families from everybody else. And this really helped to reduce the gorillas getting COVID. We engaged Right for a Woman, who supports local women who are disadvantaged, and they started to make masks for people who were visiting gorillas. And this helped to keep them busy in the absence of tourism, because poaching really went up during the pandemic when there was no tourism. And through this global coffee brand that we developed to save gorillas, we then, during COVID, we had a big challenge because there were no tourists coming and they were the main ones buying the coffee. And so we teamed up with Manny Robbins in the UK, who started ordering lots of coffee. And this really helped to also keep the farmers out of the forest during the pandemic. But sadly, we lost this gorilla due to a hungry bushmeat poacher who was hunting bush pig and duiker and accidentally killed the gorilla. In Uganda, people don't eat gorillas, unlike other countries in Africa. But Rafiki was killed. And then we had a meeting with the reform poachers, and the women, they came with their wives this time around and admitted that they urged their husbands to poach when there's no food on the table. So it also showed us the importance of talking to both men and women equally. And when we checked on Rafiki's group 1 month later, they were very unsettled. But this particular porter who took me had a mask in memory of Rafiki. So the community was very upset that the leader of the group had died. But we realized that as long as people were hungry, they were going to keep going into the park to poach. So we've so far distributed over 1,000 to over 1,500 households, fast-growing seedlings, so they're able to have food even in the absence of tourism. And we've told them to continue to do it even as tourism is coming back, because they used to do it before tourism began. But when tourism began, it was much more lucrative to carry somebody's luggage to the gorillas. And what you earn in 1 day, you could earn in 1 month just by digging in your garden all day long. But what we've done is got them to do it properly, using proper soil and water conservation methods, so that they'll always have food and not depend on tourism to meet, to address their food security. And we developed a policy brief together with the International Gorilla Conservation Program under the Africa CSO Biodiversity Alliance. And it was launched in July this year. We're very excited about that at the IUCN Africa Protected Area Congress. And this policy brief was basically talking about responsible tourism to great apes. You should be willing to wear a mask, maintain a distance, and come when you're not sick, carry out strict hand hygiene, and give back to the communities that you meet. Because Uganda and Rwanda are farthest ahead in tourism, and other countries, there are as many as 13 countries in Africa which have great ape tourism at 33 sites in Africa. 13 out of 21 countries have had great ape tourism, but it's not as well developed as Uganda and Rwanda. So this policy brief is sharing lessons learned across the continent so that everybody adopts these measures. And ultimately, the great apes will be able to actually provide sustainable financing for conservation through a One Health approach. We're addressing most of the SDGs, poverty, hunger, zero hunger, good health and well-being, gender equality, decent work and economic growth through the farming, reduced inequalities, responsible consumption also through gorilla conservation coffee, life on land and partnership for the goals. So we're excited that we're able to address most of the SDGs through our work. And we believe that this is a very good way to address everything in a holistic way and to move. And I've recently written a book, which is coming out now in February, but it's available for pre-ordering, about my conservation journey, which has been shaped by One Health. And I hope you get a chance to read it. And I was excited that Dr. Jane Goodall wrote the foreword. She's a very great advocate for integrated approaches. And Jane Goodall Institute developed our health program in Gombe National Park many years ago called Takare, which was supporting community development to reduce the pressure on the chimpanzees at Gombe. And for more information, please visit us on our website and follow us on social media. Thank you very much. Looking forward to your questions.
Excellent, thank you. So I think we'll wrap up now, and I'd just like to say thank you to our two speakers, Joe and Gladys. I'd also like to extend thanks to Joe Alcamo as well, from the Sussex Sustainability Research Programme, and Carlos as well, who's hiding behind there, who's organised, marketed, and also done the technical stuff. Thank you.